I'm Nicole, a continuing education coordinator for the Collaborative for Accountability and Improvement. Thank you for joining us for today's webinar, Measuring How Healthcare Organizations Respond to Patients After They Experience Harm. Today's webinar will feature authors of the recent article in Frontiers in Health Services titled the same. I will put a link to the article momentarily. So the session will start with a presentation by Lauge Sokol-Hessner, followed by an engaging panel discussion with Carole Hemmelgarn, Beth Miller, Diane O'Connor, and Leilani Schweitzer. I will briefly introduce Dr. Sokol-Hessner before handing over the session to him and his colleagues. So feel free to submit questions into the chat or Q&A as they come to you. We'll address questions after today's panel. So Dr. Lauge Sokol-Hessner is a hospitalist and an associate professor of medicine at the University of Washington in Seattle. He is also the associate director for the Collaborative for Accountability and Improvement. Dr. Sokol-Hessner has led communication resolution program work in several ways, communicating with patients and families after adverse events, leading a medical center's peer review program, a member of the leadership team for the Massachusetts Alliance for Communication and Resolution After Medical Injury, and coaching and supporting several hospitals who are currently implementing CRPs. So thank you, Lauge, and thank you to all of our panelists today.
Great. Thanks, Nicole. Can you just give me a thumbs up if the slides are all right there? Great. Excellent. Well, excited to talk with you all about this topic today. I'll just start by saying I don't have any disclosures, and I'll start by saying thanks to colleagues and co-authors of the paper and the panel. Really, everything I'll be talking about today is the work of many, so it takes a village. Our objectives, we're going to talk about best practices for responding after patients are harmed by their care, CRPs, and I'll just, this audience I think is largely familiar with CRPs, but I'll just highlight some of the evidence and challenges with implementation. We'll talk about the perspectives of interested parties about CRP measurement, and really that's what our panel is going to do today, sharing their perspectives. And then we'll talk about why CRP measurement is necessary and some potential next steps. So we'll really kick off the bat just by saying that CRPs, Communication and Resolution Programs, the modern ethical paradigm for responding after patients are harmed by their care, they're an evidence-based practice that works. The evidence is growing. The recent ARC literature review, we have our CAI evidence compendium, the link's at the bottom there if you're interested. But overall, the communication that's part of CRPs lead to better emotional and psychological outcomes for patients and families, better socio-behavioral outcomes, meaning less avoidance of doctors and facilities. For clinicians, there's some evidence that they can help with processing of events, allowing them to go back to meaningful and productive careers. And for organizations, CRPs are fully aligned with the culture of safety. There's good evidence that they lower the rate of claims and defense costs, and they may lead to a shorter time to resolution. So all that sounds great. There are many organizations that, partly because of this evidence, support CRPs. There are a number of entities that promote proactive communication after events that you can see listed here. And there are some entities that specifically encourage CRPs, including PCAS, the President's Council of Advisors on Science and Technology in 2023, the forthcoming CMS Patient Safety Structural Measure, which I'll talk about more in just a few moments, that specifically encourages CRPs, and AHRQ, AHRQ, the Agency for Healthcare Research and Quality, has its Candor Toolkit, was published in 2016, and has identified CRPs as a patient safety practice. Despite all of that, all the evidence, everybody, all these entities saying, hey, this is a great idea, we should do this, we find that implementation is inconsistent. There are a lot of organizations that don't have CRPs. Even those that do may not be applying them or using them reliably. And I think there are a lot of different reasons that this might be the case. There are articles about that topic in particular, why implementation is so challenging. But one of the ones I want to highlight today, and we're really going to talk about, is this lack of measurement. The lack of measurement, I think, is a major contributor to this problem, and I hope that we can convince you of that today and also start thinking about ways to solve that problem. So that challenge is what led us to write the paper that we'll be talking about today. I'll just highlight our authors here: John, Carole, Beth, Diane, Melissa, Leilani, and Matt, many of whom are here today. And we really wanted to have this diverse group, which are all affiliated with CAI, Collaborative for Accountability and Improvement, or PACT, the Pathway to Accountability, Compassion, and Transparency, and our PACT Measurement Network Work Group was really how we came to work on this topic. We wanted to have these diverse perspectives, patient family advocates, quality and safety professionals, healthcare organization leaders, clinicians, and those with measurement expertise. And that's a good tent. I think we probably need an even bigger tent as we move this work forward. But that diversity of perspectives is a really important part of what we wanted to bring as we started to organize our thoughts and share them with you all. So we're going to do a Slido as I begin to talk about this paper. For those that are unfamiliar, Slido involves taking your mobile device, if you have it, point your camera at that QR code, scan it, click on the link to open the web page, and you can vote. If you don't have a mobile device, you can go to the internet, open up a web browser, go to www.slido.com, and enter that 7-digit code there. And go ahead and vote and let us know, what do you think, where is your organization with measuring its CRP? And if you're not part of a healthcare organization, that's fine. You can click that answer. If your organization doesn't have a CRP, that's fine too. If you're not sure, that's okay too. Just give us some sense of where are you with measurement. And once you've logged in, we'll have one more Slido after this, which you shouldn't have to log in again. So it's just that one-time process. This is great. I see we have over 100 folks with us today on the webinar, which is awesome. And I see about 37 or so have voted. For anybody else who wants to join, feel free to go ahead and do that. But I think we're starting to see already that it looks like about a third of folks in the audience are measuring their CRP. Close to a third don't actually work for a healthcare organization. That's great and fine. Awesome that we have you here today. And significant numbers are not sure and, or aren't measuring. And so it's great. I think this is a good example of we're all over the place in terms of measurement, and that's the real world. In fact, today I think is somewhat probably an enriched audience, meaning an audience that is probably doing more measurement than most. And so in the real world, if we were to do this poll out there in a representative sample, I think that percentage that are measuring are it's probably a lot lower is our theory. So as we began to write our paper, we did a sort of current state scan of the landscape just based on talking with folks, because there isn't any good measurement system out there yet about who is doing CRP measurement or not. To our knowledge, most or many organizations with CRPs are not routinely measuring them. Some are, but there's no real standardization amongst those. They may be measuring in slightly different ways, different measures, different systems. And to our knowledge, none of the measurement systems that are out there are really comprehensive. And I think that really means a lot are not necessarily collecting outcome or experience measures. And I'll talk about what we might mean by that in just a moment. Most are really focusing on process measures. There have been a number of efforts to date to try and promote measurement. Some researchers have published a survey, for example, that you could use after a patient was harmed by their care and had experienced a CRP. There's state-based alliances. For example, the Betsy Lehman Center in Massachusetts has a measurement schema or measure set that it uses and promotes. There's a for-profit company that promotes CRPs, Beta Heart, that we believe has a measurement strategy. And then there are nonprofits like us, national nonprofits like CAI and PACT with interests in CRPs and patient safety that have put forward some ideas, and I'll share an example of what we've put forward in just a moment. So that's the current state, and we began to think about the different types of measurements. So as many know, there are often 3 different buckets, so to speak: structural measures, process measures, outcome and experience measures. Structural measures are things like, do you have a CRP, yes or no? Do you measure your CRP, yes or no? They're very structural and process oriented. Do you have a process, for example? The forthcoming CMS patient safety structural measure, I'll describe more in just a second, but that is going to be a great structural measure for us. It hasn't been there yet, but it is coming out this coming year. Process measures is really where most of the measurement has been happening. I'll give an example of what those might include. But as I've noted, they're unstandardized. There's some variability amongst organizations. And importantly, many organizations, if not all that we know of, are doing this using spreadsheets of some kind or a hybrid with software that they already use to manage their safety events, and then a spreadsheet to compile data like a Google Sheet or an Excel sheet, something like that. And then finally, outcome and experience measures. And as I mentioned, I'll give examples of those, but they are particularly unstandardized and to our knowledge are not widely used, if at all. So that's sort of the current state. So let's talk about each of these three in turn. This is the CMS Patient Safety Structural Measure as relates to CRPs. For those that are not familiar with it, the CMS Patient Safety Structural Measure, the first reporting will be due in May 2026 for this calendar year, 2025. It has 5 domains, and each domain has 5 attestation statements. So in total, there are 25 attestation statements. 2 of them are about CRPs, and those are the ones you can see here. So in domain number 4 of the 5, which is about accountability and transparency, attestation statement D is saying our hospital has a CRP that is aligned, for example, with AHRQ's Candor toolkit, and it has the following elements. And hospitals are asked to say, do you agree? Can you say yes to this attestation statement, or are you going to say no to the attestation statement? Yes, we have a CRP. No, we don't. That's what the measure asks them to do. Item E, as you can see there, asks about CRP measurement. It says our hospital uses standard measures to track the performance of our communication and resolution program and report them to the governing board at least quarterly. And again, hospitals are asked, are you going to say yes to that statement, or are you going to say no to that statement? As for what standard measures means, CMS, Center for Medicaid and Medicare Services, puts forward an attestation guide, and in that guide, you can see the excerpt there. They have said that standard measures may include the number of resolutions achieved, the amount of time for resolution to occur, and total compensation paid to patients when inappropriate medical care causes harm. It doesn't say that other measures couldn't count as standard measures. It just says they may include these. So that's the current state for the structural measure. We're really excited to see what comes out of this, what gets reported, and then learn from that. And I expect there will be some evolution of this over time as we go along. The second bucket is process measures. And again, I think this is where most of the measurement activity has occurred so far. There are lots of different process measures out there. What I'm sharing here with you is what we at PACT have, as a network measurement work group, have proposed as a minimum data set for organizations that have fully launched a CRP. So organizations may be in a variety of places with CRP implementation. They may be early in their journey, somewhere in the middle, or they may have fully launched it. For those that have fully launched it, we recommend they collect at a minimum 4 data elements for each CRP event. In other words, for each event that qualifies, that involves moderate or worse harm, and they apply their CRP, they should be tracking the event report date. When was that event? When did that event come to their attention? When was the initial communication with the patient and family completed? When was the post-event review communication with the patient and family completed? And what was the overall outcome of the process? Meaning, did we try to use the CRP for this event? Did the patient and family engage? Did we refer it to claims insurer? Did a claim or litigation happen? If we did make an offer, was that accepted or not? And those are all designed to be mutually exclusive categories. You would pick one of them, for example. With those 4 data elements for all CRP events, sites could then calculate the number of events they had per unit time, the timeliness of the communication, those major communication events, the initial and the post-event review communications, the timeliness of the overall process, the reliability, how often those communications are happening, as well as the outcome of the process in terms of just where did it end up. For organizations that are willing, able to do so, we also encourage them to collect patient-family preferred language, which can help them begin to identify any disparities that might be happening so as to drive towards equity. So that's an example of a process measure strategy. Our current cohort that we're working with has recently got introduced to this, and so we'll be seeing how this works for folks in the real world. Outcome and experience measures was that third bucket, and I think this is one of the most interesting buckets, and I'm really looking forward to our panel's thoughts about these topics today. There are a lot of different outcome and experience measures we could be considering, and there are a number of different groups to be considering, or types, as you can see on the slide here. For example, for patients and families, we could be asking, after you're harmed by your healthcare, what effect has that had on your well-being, your health? What about on your levels of trust? Did you feel the process was fair? How willing are you to return to that organization or recommend that organization or those clinicians to other people? To what degree were your information and support needs met, including any compensation you may have gotten? What was the quality of the communication that you experienced? And what did you think about the organization and the professionals with regards to their honesty, how respectful they were, their accountability, compassion, transparency? Did they engage you in the learning and improvement process? There are many different things we could be asking about, and all of these at some level I think are important. It also may be hard to ask about all of them, just for logistical reasons. I'm sure folks have gotten surveys over time, and sometimes surveys are a little long and we don't want to complete them, so there's challenges there. For clinicians, I won't belabor it, but you can see there's quite a few things I think for them we could also be thinking about, including their intent to stay in their role or at the organization. How were you supported in the aftermath of this process? How does that change the way you feel about things? For organizations, that's where most of, I think, the research to date has been around the organizational experience of malpractice, medical legal experience, and cost. That's where the studies have been, the research studies. But there's more that could be looked at. How do CRPs affect your reputation, your culture of safety, and other important metrics? And then lastly, patient safety, definitely not least, but CRPs are designed to be improving patient safety. And so could we actually begin to track the number and type of CRP events and ideally see them decrease over time as we get better, get safer? And how are we doing in terms of sharing what we're learning and improving beyond the organization so that we're driving improvements more broadly, more quickly, because we definitely need that. Lots and lots to think about in this space. I also can imagine that as many of you are hearing this, you're thinking about some of the challenges getting this all done. Sounds like a lot to do. These are some of the challenges that came to mind for us. For one, as I've noted several times already, there are no standard measures. And the lack of standardization, I think, really makes things challenging. We'll talk about that more in a moment. Two, the logistics, especially for outcome and experience measures, are particularly tricky. When is the right time to reach out to a patient or family who've recently been harmed by their healthcare? Too soon may not be right. Too late, maybe some of the details may be lost or it may be harder to recall. When is the right time? When's most respectful? What about methods? Or should we be doing that in person or by phone? Is it okay to send an electronic survey or a text message? What's the best way to collect those data? What about the results? Are the results anonymous? Are they identifiable? Could the organization learn how a patient and family responded in a particular scenario, what their answers were? What about confidentiality? What about legal concerns? Some organizations may worry that surveying patients who've been harmed by their care could expose them to liability in some way. There are a lot of key questions here that nothing I think that is insurmountable, but all of this would need to be thought through carefully. I think the third bullet here, the fact that these measures, process and outcome and experience measures, are not currently built into any of the software that organizations use to manage these events. That software is often called patient safety risk management software. It's a little bit of a mouthful, but basically it's the software that captures events where clinicians can report events, and then the events are managed over time. And that software, almost every organization has software. Some still use a paper-based or spreadsheet-based process, but most have some vended software that they use. And that doesn't include standard metrics of any kind currently. Similarly, data analysis and CRP performance reporting are manual processes. There's no button you press and it does all the analysis for you and spits out a nice graph that you can share with your board. That would be nice if that happened, but to our knowledge, that's not necessarily a feature that's widely a part of software. And all of that work to collect the data, compile it, analyze it, report it, often falls to CRP teams. CRP teams are the interdisciplinary teams that run the CRP in an organization. They're often patient safety, risk management, patient relations professionals, and others. And in talking with them, they often report they're real busy. They're overburdened, under-resourced. It is hard for them to add more to their plate, to ask them to do yet more in addition to actually managing the events and taking care of everybody who's been hurt. So there are a lot of challenges here. This is the second Slido. I now want to ask you as an audience, as you are thinking about these challenges, which ones rise to the top for you? So If you didn't log in before, go ahead and scan the QR code, or you can go to the website like I described. If you did log in, if you just go back to your device on the web page, it should automatically update with this new question. And go ahead and rank these challenges from what you perceive to be the most important at the top to the least important at the bottom there. And we'll see what the results look like. We'll give a moment just for folks to vote. Is it a problem with data analysis, logistics, standard measures, resource constraints? What are the issues that seem to matter most to you? And we also know that many in the audience aren't necessarily part of a healthcare organization or don't have a CRP or aren't measuring, and that's fine. Just for those that are, we'd love to learn from you. We've got about 30 plus people voting now, so that's great. And I think what we're seeing, resource constraints, is coming out on top. And that's what we anticipated. That's really helpful to hear from all of you. I also think this lack of standard measures is an interesting one. Resource constraints can be hard to alleviate, but standard measures is something we could build as a field. And so I think that's a really great opportunity. The logistics, we'd have to think through. Data analysis issues matter, and then for some there are other issues. But thank you. This is really helpful to see, and I think our panel will be able to comment on this as well. There are a lot of different perspectives on CRP measurement, and I won't belabor this too much because our panel is going to share their own perspectives. But I do want to highlight some of the key things that come out in the paper that we wrote, and I encourage you to read the paper if you want to see a deeper exploration of these topics. Overall, patients and families want measurement, especially for outcome and experience measures, especially for those who are most vulnerable. And they want organizations to be held more accountable for how they respond after harm. There currently are no measures required of organizations tracking how they respond after patients are harmed by their healthcare. It's a real opportunity. Clinicians definitely want their patients to get good care after they're harmed, but they themselves have their own needs too. They have support needs, and so measures of that may be important to them. Clinicians sometimes also raise questions around, well, hey, if I talk with patients and families, does that change my insurance coverage? Will it make it more expensive for me, my malpractice premiums? And what about reporting? Am I more likely to get reported to the National Practitioner Data Bank if I do this? Some of those are important research questions and maybe best answered in a research context. What the kind of measurement we're mostly talking about today is operational measurement, meaning in a real world CRP, just as we conduct it. But I think it's good to know about some of those interests, and those may be important operational measures to track at some level. CRP teams, I think, are in some ways at the crux of measurement because it's their work that's being assessed by measures of CRPs. And so I think they have a particular interest in, are the measures fair, accurate, feasible? We saw the burden is a big issue here. Are they actionable, and are they context sensitive? Those are all important things. And do they drive towards learning and improvement rather than being about judgment or punitive in some way? And lastly, organizations, I think many are interested in the benefits of measurement, and I'm really interested to hear from Diane and Beth about their perspectives on this. Some organizations are concerned about any requirements in this space because of those resource challenges. And some are concerned that, I think many organizations are fine with measurement in this space, but some are concerned that measuring could cause reputational injury by quantifying the number of harm events, or it could become a liability or be used in some punitive fashion. So suffice to say, there are a lot of different perspectives in this space. So why is CRP measurement necessary? Well, I think without measurement, we're really flying blind. We're in a data-free zone, as I sometimes say. We don't really know what's happening unless we measure. And I don't think that's acceptable. I think we can do better. Without knowing what's happening, it's also hard to identify opportunities for improvement. What are the best practices? Who are the top performers? What can we learn from them? And to identify areas that really need more innovation to get better. And we're perpetuating the status quo of there being a lot of harm from healthcare, some important proportion of which is serious and preventable. And so without data, we're really allowing that to persist. With measurement, I think we can better inform implementation. We can promote internal accountability, meaning giving organizations information, data that they can use within their walls to learn and improve. And we can drive continuous improvement and innovation. And with standardized measures, I think we unlock another possibility, which is facilitating data collection. If there is a national standardized measure set for how organizations respond after harm, that could be more easily built into software. It'd be also allowing for comparative analysis among organizations and benchmarking to really drive learning and improvement at a much broader level. There's going to be more to come from our panel about their perspectives and about the benefits, so we're really looking forward to that. But just before I do that, I want to leave us with our vision for some next steps for CRP measurement, and we'll be asking our panel to think about this. And in the paper, we outlined 5 potential next steps. One being building a coalition of interested parties. And I noted that we had a village to write this paper. I think we need a bigger village to do the work going forward. All of the folks and the roles that were part of our paper, I think, are good examples. Patient family advocates, clinicians, CRP teams, and all the professionals on them, healthcare organization leaders, but also healthcare measurement experts, public and private payers, I think representatives from patient safety risk management software vendors and health information technology regulators could all play a really important role in getting measurement right and getting it out there in the world. 2, I think we really need to address these barriers to measurement. You all identified that resource constraints, from your perspective, was the #1 issue. And I think minimizing the burden of measurement is a really important place to start. There already are a gazillion measures out there. How can we be really efficient and high value with the measures that we choose? I think co-designing with software vendors is one way to do that. 2, I think, is talking with them about, hey, these are the key functionalities that we need about data entry, management, data analysis, how we visually display results. How can the software help us do that work rather than putting that on people? And then are there other improvements that we could make to reduce the workloads on these busy patient safety professionals? And are there a role for incentives or requirements for these vendors? Electronic health records are subject to some requirements around interoperability and basic functionality, meaningful use criteria, but no such requirements exist for patient safety risk management software. Is that something we should be building? #3, sorry, is using formal measure development processes. And what I mean by that is, for a while in the field, we've encouraged healthcare organizations to build out measurement. Say, try some measurement, build whatever is going to work for you, and let us know how it goes. And I think in some situations that can be a great strategy, but partly I think because of this resource constraint and the logistical challenges, that hasn't really happened. We haven't had the organic growth of measurement that we wanted. So I think more formal processes are going to be important. That means developing measures, piloting, testing, making sure they're feasible, that they're high value, refining them, and then beginning to spread them. And that may require grant funding or other organizational structures to do that. 4 is a nationally recognized standard CRP measure set. We've talked, I think you all identified lack of standard measures as the second most important factor, and we agree. I think it's going to take a while to get to really a full comprehensive measure set, but I think we could begin now by standardizing what are the events that we agree every organization should be tracking and measuring. Maybe we start, rather than moderate and severe, maybe we just start with severe. Wherever we can get consensus, I think, is important. And then develop some process measures. We've put sort of examples forward today. There are good process measure sets in other places, but how could we begin to build out some standard process measures? If we could do that, I think we could facilitate building that into software. It would actually help organizations attest to the CMS patient safety structural measure, because then standard measures would actually have a real set of defined measures rather than the brief list that I just shared with you today. And I think it could inform implementation and drive innovation. And then in a longer term way, I think we could start to work towards standardized outcome and experience measures. They need more work before we do that, but we could begin that work. Maybe accreditation visits could begin to be a way to say, hey, are these measures being accurately collected and calculated? Make sure that the measurement is high quality. And at some point, maybe we could build in standardized measures to required patient safety measure sets. There's nothing in there now, but if we could build this, that could become a part of those measure sets, and maybe at some point consider public reporting. So lots of opportunity there. And lastly, once there's data and data starts to be accrued and compiled, analyzed, I think it's important we develop methods for sharing data amongst organizations. And This is a challenging topic. How do we do that? There is a need to have a safe space where organizations would feel comfortable sharing this kind of sensitive data. Without that, it's hard to promote learning, dialogue, and improvement. At the same time, we need to make sure that whatever systems or processes are used, whether that's a patient safety organization or something else, isn't just shielding the data, that we're actually using it to develop learning that can be shared more broadly to really drive improvement. Transparency is a core tenet, a core principle of CRPs. And in sharing data, we would need to make sure that the key lessons and learnings were being shared and we were being transparent about that rather than just hiding in a administrative structure. That would then also allow for development of comparative analyses and benchmarking and really focus on this shared goal of learning and improvement. So that's a broad overview of lots of interesting work that could be done. I'll briefly introduce our panel and then we're going to open it up for some discussion with them. And then we'll also allow you as an audience to ask questions. So I see there are some things in the chat. If you have a question, go ahead and feel free to put it in or use the Q&A function if that's an option for you. We'll try and get to as many of those as we can. So we've got 4 folks. Nicole mentioned we have Leilani Schweitzer, who's a patient family advocate and really an expert in harm response. Carole Hemmelgarn, who's a founding member of Patients for Patient Safety US and director of the Executive Masters for Clinical Quality, Safety, and Leadership at Georgetown University. Beth Miller, a nurse by background, who's the System Director for Patient Safety at Common Spirit Health. Common Spirit Health is a really large healthcare organization, about 140 plus hospitals, 2,200 care sites, active in about 24 states, and Beth sort of oversees patient safety activities for all of that, so a really national perspective. And Diane is the Executive Director for Patient Safety and Quality at Johns Hopkins Medicine, which also has multiple sites and has recently gone through CRP implementation. And both Beth and Diane, their organizations are doing measurement of CRPs. So I will stop sharing my slides, and I think we've got our panel. Thank you, everybody, for joining. This is great. And maybe I'll actually start by asking our patient family advocates, Leilani, Carole, when you reflect on your experiences in this space, what kind of measures do you feel matter most as you think about this topic?
I'll jump in here. So I had the privilege of working with patients and families and administration for 12 years and talking with patients and families. So, and then I have my own experience. And so the 2 measurements that I think I would love to see would be from the administration side, how long between the event happening and when we found out about it. So we meaning risk management, patient safety, however, because I think that if that's a significant amount of time, that's kind of a barometer or an indicator of the health of your efforts. And then what I'd like to see is asking patients and families, and I don't think this should be a survey, I think it should be a phone call or a meeting, and just ask, were you able to ask all the questions you had about what happened to you? Because I think that, to my mind, that is the most important, that is my personal most important goal for patients and families, is to have the opportunity to fully understand what happened to their own bodies or to their loved ones. And I think that if that's a measure, if they say no or if they say yes, that is an indication of the health of our CRPs. And also recognizing not everyone, you can't please everyone always, and that's just a truth. But those 2 things I think are really important.
Thanks, Leilani. That's great. Carole, what do you think?
So, Lauge, I think the first thing is this is all about transparency. And that is one of the most important things to patients and families. While structural and process measures are easy to capture, the data with the soul measures that matter most to patients and family are the experience and their outcomes. And that's really what we are lacking. And I know you address that. The other ones are tactical things you can do, but what will change the organization and really show transparency is getting with the patients and families and asking them, were they treated respectfully? Like Leilani said, were they able to ask all their questions? The outcome side of it. And the other thing I just want to address here is being part of the patient safety structural measure or being on the TEP. The one point that you pointed out was there's a thing they have to attest to: patient engagement and ongoing care. And ongoing care is equity to what is provided to what is provided in the organizations to physicians, nurses. So it's not, oh yeah, you can't attest to that in my vision if there's not equity to what is offered to clinicians and everyone else. So, I think there's a lot of work to do here, but it's really the patient experience and outcomes that are going to show the success of these programs.
Thanks, Carole. Really appreciate those perspectives. And gosh, there's so much we want to be knowing about what happens afterwards. Beth and Diane, I'll turn to you and feel free to bounce off what Leilani and Carole just shared. I'm curious, as you hear from them about what their interests are and where they think the real value in measurement is, how does that relate to the kind of data that you're tracking now? And where your organization is with some of those ideas?
No, I love always hearing from Leilani and Carole because it just reminds me how much we're aligned in what we hope to achieve. And one of the things that I think is really key is, did the conversation occur? Because really everything stems out of that. And so, because without the conversation, you can't have what Carole mentioned, transparency. And without the conversation, you can't have what Leilani mentioned about getting your questions answered. You have to have the conversation for anything else to occur. So where that relates to measurement is, I forget which slide it was that you showed, but you showed that second point of, looking at event date, but then event, the date of the initial conversation. Those two elements really are the foundation for almost all of the measurement that comes out of that, because without those two things, you really are flying blind and you really don't know if people are having conversations or not. And I think that maybe answers a question in the chat. Someone was asking, if there's 1 to 2 measures that are most impactful. I would say that those are the two: is what event date do you have or that you're aware of? And then when did you have that initial conversation?
That's awesome.
And Beth, I agree. The value of knowing when that conversation happened and holding ourselves accountable to, we know when the event date happens, how quickly did we get in contact with the patient? And then how long did it take for us to get to some sort of a space where we at least could share with them what happened, get their input continuously on that. I agree that is a key part to starting measurement and understanding it. And I really had written down and loved this idea that the nirvana is to get the patient experience perspective on this. And I always call it, like, what's the so what of it? Did it make a difference to the people that were impacted by it? And that's where we're hoping to get. We have our PFAC involved in a number of pieces, the Patient Family Advisory Council across our health system. We have 6 hospitals, 7 ambulatory centers, care at home. And so we have this in place everywhere in all of our ambulatory clinics. And we try to get the PFACs that are associated with those to start informing us more and more. How can we get some feedback and information? And so far to date, we haven't pursued the survey or the phone call necessarily, but what we've done is we've tried to weave into large opportunities when we have a gathering of people. We did a CRP boot camp, for example, and Carole joined and could bring in that perspective. We have an annual quality and safety summit, and we bring in everybody across our health system. 45,000 employees are invited to join. But then we'll have a panel as part of it where we talk about a safety event that happened in one of our facilities with the family. And we're trying, and even though we can't quite measure it, we're just trying not to miss any opportunities to start to get some of that data. Even though it's not systematic, we want to get there. And why can't we get that data now? What's holding us back from the measurement? What's the constraints of getting it? A lot of it is what you had described, Lauge. We have a homegrown information system to gather this data set. And a lot of people, it doesn't necessarily fit in their linear process. I've notified the patient. I've talked with the patient. We do find out that the patient's spoken with within a matter of days, if not that same day, is what our current data show. But the thing that's holding us back a little bit is being able to put together a structured way that's appropriate for us to ask minimal questions and get the data put into a place that we can all look at it and evaluate it. So right now we just take it opportunistically. So I do think that that's why I'm part of this conversation. We think that measurement is a big piece of it because you can't improve what you can't measure. And I just appreciate the directions that we've gone so far.
Thanks, Diane. That's great. Carole and Leilani, I'm curious, as you hear Beth and Diane talk about measurement and some of the benefits and why they feel it's so important, where do you see healthcare organizations struggling the most in this space when they're trying to measure after harm? What are the challenges that you've observed? You've been in this field for a long time.
Carole, do you want to go ahead?
Oh, you can start.
So I'm just going to measure by or speak to what my experience is right now. And that is I get a call from a complete stranger 2 or 3 times a month of people saying, I don't understand what happened to me. I was hurt, name the injury. So I don't know. I just don't think it's happening, let alone being measured. I just do not think that we are explaining what happened to patients and families. And I'm so hopeful about the patient safety structural measures, even though so much of it is very vague. It is raising the conversation, but I mean, we have 107 people on this call, which is fantastic. But man, oh man, there's so much need. So I just think that there isn't the expectation that we talk to patients and families, let alone measure it. So I don't know, Carole, you probably have a better idea, but that's just what I see happening.
I think what's difficult with the patient experience or outcome is something that was in the chat. How do you do it? When do you do it? If there is one thing I could just encourage everyone on here is there's this fear of just asking patients and families. You call and you say, this is what I'm looking for. Is this a good time? If they say no, may I call back in 2 weeks? Yes. We are so afraid to reach out, be it legal, be it we're afraid of reactions. Just moving forward and starting to do it reduces that hesitancy and fear. And I think that is the biggest issue we have right now with not because, I know time is a big thing, but yet we want this data. So it's more than just time. If we want the data, there's other barriers. And I really think that's the biggest concern or the issue on getting the patient experience. We'll tell you, just ask.
Thanks, Carole and Leilani. That's great. Beth and Diane, as you hear Leilani and Carole talk about that, have those issues been challenges in your organization? Have those been things you've dealt with? And if so, or if not, how has your organization navigated that? Why, how have you dealt with that?
Diane, do you want to go first? Do you want me to?
I can jump in because the thing that popped in my mind when Leilani was speaking was we call them disclosure conversations, like just having that conversation with somebody. That's very difficult for people to get comfortable doing. And so one of the things that we try really hard to do, so we, as Lauge mentioned, we've been in this implementation phase. We're kind of at the end of it, but we're still always implementing. It's been about almost 3 years now. And the thing that we keep coming back to is we have set up a systematic approach where you call the CRP team, and it's patient relations, a patient safety person, at a minimum, and sometimes a risk manager, depending on the organization. And that team is meant to be there to help the clinicians. The providers are the ones who are disclosing, helping them know how to do it and understand that it's okay. Like you're human. You actually speak with the patients and the family and tell them that something unexpected happened. We're going to find out what it was, and we'll keep you abreast of it as we go. But that training people to feel comfortable that we would be supporting them in that space, I think was the context that was the biggest hurdle for us to get through. And we implemented it in a stepwise fashion because we have so many entities. We kind of did a couple here, and then we started with the next few. And each group, you would still have the same, that was a big step to get over. So to hear you guys speak, I think that was, just starting it, just do it and get started, like you had said, Carole, I think is what helped us in a big way. And then we just started very, modestly measuring where we could. And maybe as an academic medical center, we love the idea of measuring everything anyway. So people are kind of on board, and we'll get there. But I do think that you have both hit the nail on the head, that there are many constraints and barriers to people who have not launched it. And even when you have launched it, you'll still bump into those. But just starting and getting going has helped us in each of those aspects.
And where I connect with what you're saying, Diane, and also Carole and Leilani, is that, patients and families want to be seen. And one of the best ways for them to be seen is for there to be a measurement, for there to be something that's actively being looked at, scrutinized, upheld. That's how, in some of our various quality safety functions, we really, look at the patient is through those various measurement arms. And so if no measurement is occurring at all, well, then essentially the process is invisible, even though maybe it is occurring. So I think any attempt at measurement is a good attempt. I would encourage everyone on the call that even if you don't feel like you have it perfect, just to start, like to Diane's point, I think they're a great example of that. And then also for us, I think our measurement approach has changed over time. It's had to adapt to what our capabilities are, whether it's our software vendor, process, or just the sophistication of our program. Over time, we've realized, oh, we have a weakness here. We need to really measure this piece better or more robustly. But I think just any attempt at measurement is going to be a good attempt. It's so much better than not doing anything, because again, I would argue that's how you're really showing that your patients and families that they're being seen. I had an experience with my oldest daughter where we had gone to get some lab work done. The little arm of the lab chair bonked her in the head as we were getting lab work done. She was fine, no big deal. But the experience that I had, afterwards with that organization was fantastic, because I, was talked to, treated humanly, lots of empathy, but they actually did send me data afterwards, showing me, hey, this is how you showed up in our report, and all of these things. And, as a medical person, I was so excited to know that my daughter showed up in that way. And it wasn't just a conversation, that there was actually, a lot of robust things that were going on behind the scenes. Now, I think maybe others might see it differently. Others might see it, oh, well, somehow my kid is just a number, or I'm just a number. But, I would argue that in healthcare, we spend so much time with those numbers, and we treat them with so much care and effort, that is one of our ways that we kind of deliver on our values. So that's where I kind of connect with that concept.
That's great. I want to open it up to our audience for questions that they have. I see a number of things have come through the chat, and I'll say to as folks in the audience are thinking about what questions they have and want to write them in, I'll just ask our panel if there's anything in the chat extra that they wanted to respond to. I'll say there was one question around, should we be implementing CRPs? Are they tested sufficiently? Are they ethical? And I'll just say, yes, they're quite well tested. They're extremely ethical. There are a number of articles that I'm sure we could send out afterwards about that issue. For example, there's a recent AHRQ literature review. So AHRQ is the Agency for Healthcare Research and Quality, based in the Department of Health and Human Services, that assesses patient safety practices, and that encouraged implementation of CRPs. They're recognized widely as the best practice. They're not used as much as they should be, which is, of course, why we're having this conversation today, but they're indeed much more ethical than the alternative, and really the best practice. So panel, anything else you wanted to respond to in the chat? And we can also see what new questions come in. Leilani.
Oh, yeah.
I see some comments in here about trying to reach out to patients and families and how you don't ever get a response. I've had that experience myself. But I also think it is very important to be cognizant of maybe why you are not getting a response. People, this is a very, very difficult thing for people to be dealing with.
Mhm.
They might be physically trying to recover, emotionally trying to recover. They may be grieving a loss. And it's very, to my mind, extraordinarily important not to expect people to respond in a way that works best for us. It is our job to reach out to them and make it possible. I'm not even going to say comfortable. They're never going to be comfortable, but possible. And so to my mind, that means you don't give up on people. You send them multiple letters. You call them and you say, I recognize it might be hard for you to call me back. I'd love the opportunity to talk to you. Here's my information. Like calling once and thinking you're done, you're not done. So to just recognize that people are traumatized, they're trying to recover, they already don't really trust something that has gone on, and to just don't give up on people when they don't return you on your first call.
Thanks, Leilani. That's great. Diane, I think I saw you raise your hand as well.
Yeah, I don't want to go off to, I just wanted to address one question in the chat. Was defining a CRP event is very hard. Who is being enrolled is not consistent. And that is spot on. And it is an evolution and it's a cultural shift, because whether you're one hospital, you'll see different fiefdoms and cultures, I guess, microcultures in each of the departments. So they'll handle it differently as well. But what we have found is it's to kind of keep what we call the fidelity of the process, is we try to have a lot of overarching repetitive opportunities for people to share what's going on at my location so that they're all getting the same definition. And we've had some organizations, within our health system as we've been implementing, is saying that is not a CRP case. We're like, well, actually it is. And we would treat it as that. And that's us at the health system level. So we don't work in a hospital and we can bring in the examples. We also have engaged a consultant, an external consultant from the Betsy Lehman Center, who has been instrumental with helping us set up how we approach it and put it out there. Just been a terrific partner, but then also can bring in additional examples of this is why we call it, it's from the patient's perspective. It was their temporary harm, whatever level, like we call it moderate temporary harm, that it makes it a CRP case, regardless of why it happened. It's still an expectation that we want you to have a disclosure conversation with that person and tell them, or that family, and tell them what happened because you didn't expect it, and then work on it from there. So I do think that the biggest piece of advice I could suggest is expect kind of to continually support people where they're at and repeat it, and then to also bring in a systematic approach. Like you always know, if you think this might be a CRP case, contact patient relations or contact whomever you say. And those people who talk to everybody about these kinds of cases can be a continual resource. And then they can be your partner going in to disclose with the patient. So we try to put systems and structures around it in a foundational way to make it effective. So I hope that answers your question, Leslie, but I thought it's very true. It's exactly how we experienced it.
Thanks, Diane. That's great. And I think, as we've highlighted, that getting to a standard definition there is a really key part of measurement, because it's the denominator in many ways, and we've all got to be consistent, especially if we're going to ever start to do some comparison between organizations to learn. Other things in the chat that you guys wanted to respond to, Beth or Carole?
I'd like to respond to one thing, not necessarily in the chat, and that is the word disclosure. Words matter. Disclosure is not bidirectional. Disclosure is, I am telling you. To me, these are constant communications and conversations. And the one thing I want to say, the conversation doesn't end until the patient or family says it ends. That can be a week, a month, years. And why I say that is this is a process oftentimes, but it's an emotional process that Leilani referred to. We have to find a place in our head and our heart where we can understand this, digest it, and somewhere have it sit. It'll never be great. But as we learn more information in these conversations with you, it may take us a little bit of time to digest it, which may raise other questions. So just because you talk to the patient or family once or twice, it doesn't mean the conversation's over. The conversation is over when you don't hear from the patient or family again.
Thanks, Carole. Yeah. Beth, anything to add? Anything in the chat that's sticking out for you?
I'd like to respond to Kathleen's question about the measurement of the input from the patient safety risk manager professional. I love that question. I think that's so important. You know, I can speak for our organization. Their input is all over the process. Like their fingerprints are everywhere in our measurement strategy. So they are, I would argue, probably the glue that holds the whole measurement equation together. But I do think that we have more opportunity to engage with them further, to have more dialogue, you know, about specific points of the process, you know, to make sure that we're tweaking things that need to be tweaked along the way. If there's process issues, we can make more smooth for them because their role is so integral. Our philosophy has been, because we can't, they're the work. And they're in the front of these conversations, and we want them to be spending the time having the conversation and not necessarily analyzing and having to spend a ton of time on data entry and all of those things. So our measurement philosophy and approach has been really one out of respect of that role and care and caution, to, you know, to not overburden them. And so our measurement strategy has kind of been an outcropping of that concept. So Kathleen, I love that question. I'm so glad you asked it.
Yeah, thanks, Beth. So I see we're close to the top of the hour, and I want to, I think we've gotten to many of the things in the chat. I want to close with a quick lightning round with our panel here and ask each person to tell us briefly what's the most important thing that you think we need to keep in mind as we move measurement of CRPs forward. And Leilani, I'll start with you.
Some things can't be measured, but they still really matter. And just because they can't be measured doesn't mean they shouldn't be acknowledged and this work shouldn't move forward. So it really, really matters even if you cannot squeeze any data out of it.
I love that point. Thanks, Leilani. Diane, what would you say about one really important thing to keep in mind with CRP measurement as we go forward?
I would say have your goal not be measure everything. I really loved how the suggestions that you shared in your earlier slides, because I believe them as well, is just start with at least just start and get some information as you can, and then you will evolve and move. I think what will get frustrating is the speed with which we can get there, because we'd like to be able to understand things better and more. So we'll have to figure out how we can work together to accelerate that. But that I think is the biggest piece that sticks in my head, is like, don't let it hold you back that you can't measure all. You can measure something.
Yep, don't let perfection be the enemy of good. So, Carole, how about you?
I think it's the co-design moving forward. Whatever measures, we've got to have all of the different parties involved. And especially when it comes to the patient experience and outcomes, you must have the patient and family voice, because it's what matters to them. But co-design of this, if we don't co-design it, we're not going to get it right.
Yeah, totally agree. And Beth, how about you?
I'm going to quote one of my favorite patient experience leaders here internally. Shout out to Marion Moore, for those of you that may know her. You measure what you treasure. I love that she says that all the time, and I think it's so true. You know, you tend to measure the things that you value the most. And I think that CRP is highly, highly valuable, probably one of the most important things that we do in healthcare. Therefore, it's definitely warrants lots of measurement. So I'll leave you with that.
Thank you. I'll say thank you to all our panelists. Really appreciate your expertise, your perspectives, and to the audience for all your participation today in the polls and the questions in the chat. Thank you all for joining us, and I'll turn it back to Nicole.
Yeah, thank you everyone for joining us today, and a special thank you to our panelists for such an engaging discussion today. So the webinar will be available on the Collaborative YouTube channel in about a week or so, and I would be happy to share the slides out with everyone who attended today. So look out for more information from us for some upcoming webinars, and we hope to see you again next time. Thanks, everyone.
Thanks, Nicole.
Thanks, everyone.
Bye-bye.
Bye.